also known as pump failure or ventilatory failure. This is where you have an elevated carbon dioxide level and an accompanying respiratory acidosis. The CO2 and the alveolar ventilation have an inverse relationship. So the controlling mechanism here is the alveolar ventilation. It affects the CO2. Okay, so as the alveolar ventilation increases, the CO2 level decreases. And here's an equation from your book that might help you estimate the CO2 depending on the alveolar ventilation. Ventilatory drive most commonly diminished by drug overdose or sedation, brainstem lesions, diseases of the CNS like multiple sclerosis or Parkinson's disease, hypothyroidism, morbid obesity, sleep apnea. And the clinical hallmark here is, even though he says bradypnea, for me it's decreased alveolar ventilation, and then ultimately apnea. Neurologic diseases, the signal fails to reach ventilatory muscles due to spinal trauma. Motor neuron disease such as ALS, which is Lou Gehrig's syndrome, Lou Gehrig's disease, or polio. Motor nerve disorders like in Guillain-Barré, neuromuscular junction disorders like in myasthenia gravis or botulism, muscular diseases such as muscular dystrophy or myositis. These have varied presentations, like in the Lou Gehrig's disease, the drooling, the dysarthria, and the weak cough. The Guillain-Barré syndrome, lower extremity weakness progressing upward, and myasthenia gravis, where you have the ocular muscle weakness, ptosis, diplopia, and dysphagia. And so the weakness in the myasthenia gravis is moving downward. Even though all these have different presentations, the end result is muscle fatigue and ventilatory failure with an elevated CO2 level. Ventilatory failure may occur as an imposed work of breathing cannot be overcome. Most commonly occur secondarily to the dead space to tidal volume ratio in COPD, the elevated airway resistance in asthma. Both cause intrinsic PEEP, which generate excessive work of breathing. The failure may also be caused by pneumothorax, rib fractures, pleural effusions, and hypermetabolic states such as burns. Hypermetabolic meaning their oxygen consumption is increased and the CO2 production is also increased, and so helping maintain those requirements may overwhelm the lungs. The clinical presentation for this type of patient, rapid shallow breathing is an indication of impending failure. Shallow breathing increases the dead space to tidal volume to dead space ratio as a result, and results in hypercapnia. Diminished breath sounds in a young asthmatic is ominous, so they're not moving enough air to even wheeze. Irritability, confusion, and coma are signs of worsening hypercapnia. Muscle tremors and palpedemia. The chronic respiratory failure, type 1 and type 2. Over months and years, the body develops compensatory mechanisms, and the respiratory failure becomes chronic. Chronic type 1 failures, hypoxemic, results in polycythemia, and oxyhemoglobin dissociation curves shift to the right. Cerebral blood flow enhanced by increased CO2 levels. Chronic ventilatory failure or hypercapnia, this compensatory mechanism is the renal response retaining bicarb to normalize the pH. And typically will be incomplete, but will raise the pH toward normal. So all of the following are clinical presentations of worsening respiratory failure, except choose your answer here. Decreased dead space to tidal volume ratio. Okay. In diseases, it's increased. acute on chronic failure. This concept doesn't have to be difficult, but basically what we're talking about here is we have a patient that is suffering from chronic failure, is now at this point suffering from acute failure on top of that chronic failure. This is typically brought on by bacterial or viral infections, CHF, pulmonary embolus, chest wall dysfunction, and medical noncompliance. This diagnosis brings a 49% mortality rate within 2 years of the acute exacerbation. So the key here is to treat aggressively to prevent further exacerbations. Complications of acute respiratory failure. In other words, complications meaning things that respiratory failure brings with it. And these are complications that add significantly to morbidity and mortality. For example, in ARDS, more patients die from the complications like sepsis and multisystem organ failure than from the original disease. In addition, other complications may include emboli, barotrauma, and infection are common. Non-cardiopulmonary complications include cardiac arrhythmias, hypotension, gastrointestinal hemorrhage or dysmotility, renal failure, and or positive fluid balance. The clinical presentation of acute respiratory failure. The patient with respiratory muscle fatigue presents with tachycardia, which is a cardinal sign of increased work of breathing. Then as worsening fatigue ensues, the respiratory rate starts falling, they get bradypneic, and then ultimately apnea. You may also see respiratory alternans. Full ventilatory failure. For diagnostic purposes, the ABG would have an increased CO2 level with a low pH, or hypercapnia with acidosis. The indications for ventilatory support. The goal of mechanical ventilation is constant. Supportive, and basically that's supportive therapy until underlying problem resolves. And it may not be that the problem is completely resolved, but they're not struggling from the issue anymore. Long-term support for patients with chronic failure, and then support should be aimed at the patient's specific needs. For example, ARDS patient is going to require much different management than that with a spinal cord injury. So here's a table from your text. This is table 41-3. And I know we've talked about weaning parameters in the past. So this is a table of weaning parameters. The way you use this, if you look on the very right-hand column where it says support indicated. So that's the value, that's kind of the limit of the value to say beyond that limit is where you would need mechanical ventilation. If they're inside that limit, then it indicates they don't need ventilation. For example, the very top line there that says PaCO2, or support indicated with a CO2 of greater than 55. If the CO2 level is 50, that means they may not need mechanical ventilation. But if it's 60 with accompanying pH of 7.2 or less, then that indicates the need for support, ventilatory support. So that's the way you use this table. And if you look through here, there's a couple that I need to point out. The maximum inspiratory pressure in centimeters of water. This is also referred to as the NIF, that you're going to hear it called. The NBRC likes the maximum inspiratory pressure, but you'll hear it called NIF. I don't know, it's just fun to say NIF, I guess, clinically. It will also, the negative inspiratory force would be less than -20. And so I'm thinking, yeah, that would be right. If the pressure is greater than -20, then that is support indicated there. In addition to the tidal volume, or the vital capacity relation to the tidal volume. For the vital capacity, an acceptable value is also if you can double the tidal volume. And then in addition, another one is the PaO2 FiO2 ratio on the very bottom. This is referred to as the PF ratio. That's what you'll hear that called. Now there are others too that we'll run across. In fact, there's some 66 of them, but these are some of the main ones that we use. Hypoxemic respiratory failure. This is refractory hypoxemia, and I think I've called it severe hypoxemia in the past, where the PaO2 is less than 40, where you have severe hypoxemia. The refractory hypoxemia is a common indication for intubation and mechanical ventilation. And the way we're looking at this is if you have an 8A gradient greater than 350 on 100% oxygen, or you have a PF ratio of less than 200. Now understand too that many times a hypoxemic and hypercapnic failure occur together. For hypercapnic failure, you have an elevated CO2 level. However, the elevated CO2 level by itself may not indicate the need for support. You have to determine what the pH is too. If you have an elevated CO2 level and a low pH or an acidosis, you probably require ventilation. However, if your CO2 level is high and your pH is near normal, then it probably doesn't require mechanical ventilation. That's the chronic situation, right? Where you have chronic compensation by the kidneys, and so your pH is normal. The trend for the CO2 and the pH is very useful, and so many times this is identified by looking at the history of blood gases when they weren't in respiratory failure or they weren't in an acute situation, and let's see if they are chronic. So the significance of the PaCO2. Normally, the volume of carbon dioxide is matched. That's what that is. This volume of carbon dioxide, and it's measured in mLs, is matched by an increase of alveolar ventilation, so that the PaCO2 does not rise, does not change. If you have an elevated CO2 level, that indicates one of three problems. You either have a respiratory center dysfunction, like in the medulla, nerve transmission problems, like some of the neural diseases that we've talked about previously, or the lung and chest are incapable of providing adequate ventilation due to disease or weakness. Assessment of muscle weakness. Muscle weakness commonly occurs in the neuromuscular disease patients, but also COPD and kyphoscoliosis. The weaning parameters, or the respiratory tests that we do to evaluate muscle strength, include MIP, the vital capacity, the mandatory minute ventilation. Even though they may have some limited value if the patient is at the point where they need to be in the ICU setting, you can certainly trend their values. In other words, watch them over a period of time, and once they start to decrease their ability to perform these tests, then you would go ahead and support them with mechanical ventilation rather than let it evolve to a point where it becomes an emergency. So the MIP of greater than 20 is inadequate, but again, watch that trend and measure it over time. In neuromuscular disease, trends of MIP becoming less negative indicates impending failure. And vital capacity, MMV, have limited value in the ICU setting, as they're typically too short a breath to cooperate. It's my feeling that if it's to the point where they're too short a breath to cooperate, it's time to go ahead and ventilate them. And I'll tell you the way that we used to do this. If you have a patient with Guillain-Barré or myasthenia gravis, what you do is you go in there. Let's see, when they first get put in the hospital, is you'll go in there every 6 hours, have them perform a NIF and a vital capacity. Those are two pretty simple tests and requires minimal effort on their part typically. And they'll get good at it the more times you do it. You watch those values, and as long as they're consistent from every 6-hour test, then it's not an issue. But as they start to fall a little, as they start to decrease in value, then you change your testing regimen to every 4 hours. and you continue to watch those values. Then as the values start to decrease more, then it's probably time to go ahead and support them with ventilation, simply because, again, you don't want to progress them to the point where failure becomes an emergency. Weakness, fatigue, and failure overlap and may result in acute or chronic failure. Excessive work of breathing is the most common cause of respiratory muscle fatigue, and failure to wean from mechanical ventilation. And that's whether it's before you put them on the ventilator or after you put them on the ventilator. You always have to be concerned about that work of breathing. The imposed work of breathing if the patient is ventilated, due to the endotracheal tube. And we've already seen how small those can be. Okay, they have to be smaller than your trachea for them to fit inside the trachea. Of course, anytime we place an endotracheal tube, we want to put the largest size in there as we can because of this reason. The ventilator circuit can also create some work of breathing. Auto PEEP, this is air trapping by the ventilator just because of the way we have the ventilator set up. It can cause some auto PEEP or trapping. And then the disease process itself, whether that's a pneumothorax or ARDS or whatever it is. If you can calculate the work of breathing in joules per liter, if it's less than 0.8, you have a 96% successful extubation rate. And I put that in there because I know there's a question in the question bank that asks that, 0.8 joules per liter. Another strategy for ventilatory support is non-invasive ventilation. This provides support without intubation, and so this is a mask type of ventilation. It would include CPAP, pressure support ventilation, volume ventilation, and pressure ventilation are the different modes that are available. Clinical situations that may respond to non-invasive are acute exacerbations of COPD. First of all, just a brief history about non-invasive. This is the newest type of ventilation that's come out, and it's been around for a number of years, but it's just now coming to the forefront, and so we're seeing this more and more all the time. And it's because they've been able to use this successfully in certain situations. It's not for everybody. As you go through this, it's more like they're going to present this like a study instead of like information. And that's because it is so new. And so this is the way they can justify it or say, no, it doesn't work here, and give you specifics about which clients it works for. That's what it says here. Acute exacerbation of COPD has good evidence. The cardiogenic pulmonary edema, like in CHF, it has reversibility there. Again, cardiogenic pulmonary edema, very useful tool in treating this type of patient where we used to have to intubate them, and at that time we paralyzed everybody for a little while, got the situation under control, and then woke them up, and then had to wean them off the ventilator. And if they had underlying pulmonary disease to go with that, then it just took that much longer to build back up their muscle strength and wean them off the ventilator. I can think one instance of this, practicing in Big Spring, we had one lady that would come in CHF exacerbation, and we'd put her on the vent, we'd get her CHF under control rather quickly, but because of her underlying disease, her pulmonary disease, her COPD, she wouldn't get off the ventilator until about week 3 of the hospital, and then so she'd finally go home and stay home for a week and come back, and she wound up spending 3 out of the 4 weeks in the hospital until we got this non-invasive thing down. They would call us and tell us she's coming in, and on the way to the emergency department, we would grab the BiPAP unit and put it on her, and so we didn't have to intubate her, we didn't have to paralyze her. She'd be gone back home in 3 days, so it significantly changed her quality of life. And so I've seen good results with it. You see it more and more these days. Use in asthma is controversial because of the air trapping issue. Again, you're not using an airway. Asthma is probably not a good idea there. Occasionally, you find somebody that works real good, but that's simply not the routine case. Acute type 1 failure, improved PF ratios, but no patient important outcomes like length of stay, morbidity, and mortality. Chronic type 2 failure, particularly neuromuscular disease, improves and prolongs life and cognitive function, reduces pneumonia and hospitalizations. And so I've seen this be rather life-changing too also, where instead of putting an airway in, you put the mask on them. And most of these people have enough strength where they might be able to last a couple of hours without that mask, without the assistance of the ventilator. You know, they're not going to be up mowing the yard or anything like that, but, you know, they can brush their teeth or have oral care done. They might even eat. And so it's a life-changing mechanism when you can do that. So that's non-invasive. Invasive ventilatory support. This is indicated, in other words, we're going to place an airway here. Indications are severe hypoxemia caused by a disease that is slow to resolve, like acute lung failure. Patients needing support who cannot tolerate or contraindicated for non-invasive positive pressure ventilation. And it's effective for hypoxemic and hypercapnic failure. Now we're just going to have some specific situations where we're going to talk about ventilatory support of certain condition. In ARDS, the patient has very non-compliant lungs. And what non-compliant means is their compliance is about 10, maybe 15, 20 at best. Where typically they're about 60 to 100, something like that. And so in this type of patient, it's best to ventilate them with small tidal volumes of about 6 milliliters per kilogram. And so, you know, that's where our modern day ventilation strategy comes from, is from a thing that they did study in ARDS, and they call this ARDSnet. I'll put the link to that address. I don't know if I'll be able to link it there, but I'll put the address up in the corner here so that you can look at that. The ARDS has changed the way we ventilate patients, but this strategy reduces complications and improves survival, these small tidal volumes. So many times high PEEPs and small tidal volumes come together because of this study, and they don't have near the complications as they did when they were using larger tidal volumes and smaller PEEPs. In ARDS, we sometimes have to use a strategy called permissive hypercapnia. This is where we allow the CO2 to rise, understanding that the body will compensate for the pH. And so as our CO2 goes up, we'll start retaining more bicarb, and our pH will be, it may not be normal, but it'll be close to normal. With that understanding, then what we can do is we may even be able to decrease these pressures and tidal volumes even more and not damage the lung, so that we don't now have to recover from the ARDS and lung damage for the patient to survive. But the only thing is when they resolve, then we'll be able to ventilate them easier, and we'll control the CO2 at that time. So permissive hypercapnia is a strategy we see quite a bit these days. Another strategy that we use is for the head injury. In the head injury, there's a problem with intracranial pressure a lot of times. And so because of the brain is enclosed inside the skull, if it swells, what it does is increases the pressure inside the skull and compromises blood flow. Sometimes monitor that intracranial pressure so as to not compromise the blood flow. So in doing that, in the short term, we can hyperventilate the patient to about CO2 of about 25 to 30 to alleviate the increase in ICP. As we do that, we have vasoconstriction. Remember that CO2 is a pulmonary blood vessel dilator in the brain. As we think about this, if we can blow off the CO2, then we have vasoconstriction. We still have blood flow, but we're taking up less room, decreasing the pressure, have less volume inside the blood vessels, and so it then relieves some of the intracranial pressure. In the long term, once that short term is over, after 24 hours or so, long-term support, you're going to maintain the CO2 between 30 and 40. Again, because of the compensation that occurs when your CO2 is low like that. In addition, PEEP may increase the central venous pressure, decreasing the pressure gradient for the cerebral venous drainage, which in turn elevates the ICP. again, what this is saying, this is you have to drain the blood out of your brain. And if your CVP is increased, your central venous pressure is increased, it compromises the drainage from the brain. That's another cause of increased intracranial pressure. In other words, we got blood that's hanging out in the brain because it can't flow out. We can do this by raising the head of the bed. We can alleviate that to some extent. And in some cases, we have to use ICP monitoring. And most of the time, these types of patients are under a very strict minimal stimulation type order. So this is not a patient that we get to go in and talk at bedside. You go in there and you get your job done, and even doing your charting, you do it outside. You go in there and look, or you give them a treatment, you suction them, whatever you need to do, you still got to do it, but minimal stimulation at bedside. And I say at bedside because even just the presence of someone in the room, just standing there, being quiet, not approaching the patient or anything, can increase their ICP. That's a form of stimulation. So you get in there and get your job done, and you get out. You don't no messing around there. The next situation is for COPD. The ventilatory settings are optimized with a low tidal volume of 6 to 8 milliliters per kilogram ideal body weight, have a moderate respiratory rate, have a high inspiratory flow rate from 70 to 100 liters per minute, which typically normal would be around 60. And so as you increase that flow rate, the inspiratory flow, this reduces the I time and allows a longer exhalation time, which is required by this type of patient because of the obstruction. So this minimizes auto PEEP. So you can set a PEEP to alleviate imposed work of breathing and asynchrony associated with auto PEEP. Now remember that auto PEEP is air trapping caused by the ventilator. So if you can measure that auto PEEP, what you do is you go in and set the PEEP at the same level as the auto PEEP, and that gets rid of that work of breathing associated with that, and the patient will be much more comfortable for it and better off. Their work of breathing will also decrease. Next situation is the chronic ventilatory failure patient. The goal here is pH related. Even though we're going to ventilate them, they're already compensated, right? They have a high bicarb because they've been retaining it for years and years. We're not going to go in there and put this type of patient, give them normal values. In other words, we're not going to ventilate them for a CO2 of 40 because that's not their typical value. It might be as high as 60, 65, 70, something like that. And so as we ventilate this type of patient, we have to keep that in mind, that they probably have a high CO2 to begin with. We're after a normal pH here. All right, so we want to obtain a CO2 that gives us a normal pH. Metabolic alkalosis can produce hypokalemia, seizures, and arrhythmias. If your CO2 is normalized, in other words, you take this chronic failure patient, which typically has a CO2 of 55, and you go in there and ventilate them till their CO2 is 40, their blood gas is going to look up like a metabolic alkalosis because their pH is going to go up and their CO2 is going to be normal. So they look like a metabolic alkalosis. And when you do that, this will prolong the weaning of the mechanical ventilator, making it difficult to get them off because there's no way they can sustain that level of ventilation. So when you're looking at the blood gas of the chronic failure patient, you have to look at their underlying typical values and use those to guide your ventilation.